so one of the advantages of Zoom is that we can see names. So you already know what my name is. You can see that my name is Stuart Eglin. It's great, isn't it? When you're sitting in a room, you kind of try and remember names and then you think, I'm not sure I've got all of these. I can see names of you, so that's really helpful. I'm going to start now, and as I'm speaking, I hope that other people will join us. But let me just begin by saying who I am and taking just a few minutes to explain what we're going to do over the next couple of hours or so. So I'm setting the scene, essentially. So this is the fourth seminar in a series we're calling the Provocations Seminar Series, which is a piece of work we're doing jointly with the University of Liverpool's Faculty of Humanities and Social Sciences. I'm from an organisation called NHS Research and Development Northwest, which I'm hoping you're aware of as well. I work with that team particularly focused on this programme of work. There's other people I'll introduce in just a moment, but let me just tell you a little bit about Provocations. So, let's say this is the fourth of these seminars, and what we're aiming to do here is to run an event in two parts. The first part being the provocation, and the second part perhaps we think of as creation. So in the provocation part, what we're doing, we're really lucky to have with us today Professor Lynn Sudbury-Riley, who is going to be talking about her research. I'm hoping that those that didn't see the film that we showed at 11:45 have had the opportunity to see it already, and you'll have seen an incredibly powerful message that captures the essence of the research that Lynn's been working on. That film was done a little while ago, and by good fortune this week is a very timely opportunity for us to run this seminar, since the inquiry that was mentioned in that film actually started yesterday. So Lynn's very in demand this week, and we're very lucky to have her for the next 2.5 hours spending time with us talking about that research. But this isn't a one-dimensional seminar. It's not a kind of thing where you come along and Lynn talks at you for a couple of hours and you take notes and think, well, that was very interesting. This is a dialogue. So there will be an opportunity in the first part to respond to Lynn's research with a provocation. So Lynn has set 3 questions, which I think you've already seen in the paperwork that's gone out. There'll be an opportunity for you to get into some dialogue once Lynn's set the scene about those questions, to react to the provocation. And then in the second part of the event, I call that creation. That's much more of a dialogue around what you're bringing to this session, what you're working on, where you work, if you're active in research, the research you're bringing, to think about how Lynn's provocation might have implications for you, for your work, perhaps for your life as well. And that, maybe think about that. That could be in terms of method, the kind of work that Lynn's been doing. It could be the content. So we're very open about that. And that second part that we'll come to around 1 o'clock is an opportunity for you to take the agenda and run with the agenda yourselves. Okay, so hopefully we'll explain that a bit more as we go along. So don't worry about the detail of that too much at this stage. I want to introduce, I've already mentioned Lynn Sudbury-Riley, and I want to introduce Amanda Craig. Amanda's the Chief Exec of NHS R&D Northwest. Amanda will be co-facilitating this process today. And Joe Simpson, who's the tech, design, Zoom, everything behind the scenes. So if it all runs smoothly, Joe takes all the credit. And as I was joking earlier, if anything goes wrong, it's all my fault. So we'll put it right, don't worry. Any problems, just drop a note in the chat, and we'll kind of take it from there. And we'll do what we can to resolve it. I'm confident this will run smoothly, he says very, very boldly, but let's see how it goes. So just a couple of things to say, and then I'll be quiet and hand over to Lynn. We're dealing with a very sensitive topic today. I have no idea what you're each bringing to this, to the room today, and what you bring by way of that. We want to be mindful of that and conscious that this is a very emotive subject. So I would just ask that as we join breakout rooms and enter discussions, we're all mindful and compassionate about that, and that we're aware of the sensitivities of the topic. We're dealing with bereavement here, and loss and grief. So if we could please be patient and kind with each other, that I think will end up giving us a very worthwhile and kind of productive and fruitful session. So that would just be a plea from me. I think that's all I need to say. I'm looking at the screen at Amanda to see if she's thinking, Stuart, you haven't talked about X or Y.
No, I think we've mentioned that the session's being recorded, Stuart, because everybody's accepted the notification that it's being recorded.
Yes,
just to reassure you, we're going to use that material to help with the evaluation process and the next step process after this. So that's where that material goes to. So thank you, Stuart.
Okay, and just on the recording issue, so the main room, I'm sure a lot of you are familiar with Zoom by now anyway, but this main room will be recorded, and that's what we will use by way of a film. When you're in the breakout rooms, they're not recorded. There's no mechanism to do that. You can discuss and share openly, and that's not going to be disseminated anywhere else. So feel free to do that. I think that's all I need to say. I'm going to hand over to Lynn now, and Lynn has a 20-minute presentation that she's going to share with us. So over to you, Lynn.
Thank you so much, Stuart, and thank you, Amanda and Joe and everybody else who's had to put this together several times. I know it's been a difficult one, so thank you for this opportunity. Host disable participant screen sharing. So, Joe, if you could enable me to share my screen, please. Thank you. Can everybody see that? Yeah, okay, great, thank you. I didn't know what to call this presentation today, so I think I've settled now for unable to get through, because I think that was a message that came out of the research, unable to get through in so many ways and at so many different points in time. Wanted to give you a little bit of personal background, really. My dad got taken into hospital early in March 2020 because of a problem with his foot, and he had to have surgery on his foot, and a few things went wrong after the surgery, so he ended up having to stay in during a time when Liverpool were playing Atletico Madrid, and the Spanish fans that weren't allowed into sports stadiums in their own country were allowed into our city, despite the people from Italy saying, "What are you doing? Please stop." And at that time, the then Prime Minister Boris Johnson is saying, "We can send this virus packing." He was saying that on the 19th of March, despite us having to go down into lockdown on the 23rd, which was codified in law on the 26th. All that was too late for my dad. He called COVID in hospital, and he died alone on the 29th of March. And I knew, I'd lost my mum 10 years earlier. I knew that being bereaved during the pandemic was very different to being bereaved at other times. And I said that in the film. About 10 months later, I came across a Facebook group, and it was a group of people called COVID Bereaved Families for Justice. And what they were asking for was in a statutory public inquiry into the handling of the pandemic, because, as they said, being bereaved during COVID was very different. And I thought, gosh, it wasn't just me who felt like that. And my background, my research background, I research people, consumers who are, when they are at their most vulnerable. That is my research area, my research umbrella. And for about the last 10 years, I have specialised in palliative and end-of-life care, death and bereavement services. And this Facebook group was very much an activist group pushing politically for an inquiry. But interspersed with these political statements were also expressions of grief from people who said, we've got nowhere else to share these stories. And given my background and given my research area, I just felt compelled to have to do the research. So I started looking at what had been published from an academic perspective. And there was a lot of speculative writing, but not a lot of solid empirical studies at the time. And there were also reports starting to come out. There was Amnesty International's, there was a couple from the CQC, and yet nobody was sort of asking about the bereaved. And so that's the background, if you like, to this study. And I started collecting data in the spring of 2021, and the lay report was published around the autumn of the same year. So prior to us getting the statutory inquiry, which, as Stuart said, has already, the preliminary hearings have started. During the writing up of the report, it came out about the government's parties and Partygate and everything. And of course, then we've had Matt Hancock's revelations today, and there's going to be a lot more to come. So I think although the research was done, 18 months ago now, nearly 2 years ago, it's actually just as current as ever. And this is what Amy said, and it sums up what everybody was saying. It's a death that's like no other, and unless you've experienced it, it's really difficult to explain, and it's an experience like no other. And I think that was my aim, is to give these people a voice and to also have a small step in helping people to understand. So my ethics obviously had to take on elevated scrutiny, and I had to go before the board several times to get ethical approval. I recruited people on Facebook. Don't forget, we were in lockdown. We couldn't conduct face-to-face research, so I did it all on Zoom. I put an ad on my personal Facebook page, a couple of COVID bereavement groups, including the Justice Group. And I had to remove it after 12 hours because I was completely inundated with requests from people to share their story. About 70 odd information sheets went out. 41 people came back to say they wanted to take part, which got dwindled down to 31 in the end, because some people said they felt they couldn't do it. And then on the last moment, 3 more people came out because they said they'd started to get upset and anxious at the thoughts of the interviews. So the final sample was 28 stories of people who lost 30 people between them. One woman lost both her parents, and one woman lost her husband and her best friend, who was her husband's sister. So that was where the 28 and 30 come in. I used pathographies, which is basically stories, narratives of illness. So the stories people told me started from the day that their loved ones got sick right through to the present day. And they were recorded and transcribed verbatim. They were very reflexive. They were very reciprocal. I was open and honest that I was bereaved myself. And many respondents said how they felt that they could open up to me in a way that maybe they wouldn't have been able to otherwise. So I think that was a benefit, really. And then I conducted a thematic analysis on the data. The data is rich, extensive, and it came out with 11 global themes, some of which I'm going to talk about today, but these are very briefly the 11 global themes. One was very slow responses by the NHS 111. People couldn't get through. It was unsatisfactory when they did get through. Another big issue was being unable to accompany relatives into ambulances and into hospitals, even if they were extremely vulnerable, even though a lot of the NHS website said if somebody was really vulnerable, they would be allowed to be accompanied. Another theme that we're going to focus on today is poor communication between patients and their families, poor communication between clinicians and families, poor communication in terms of decision making. And then a system in chaos. People couldn't get through. They felt very sorry for frontline staff, for nurses on the front line, and they were overworked, they were pressurized. And but because of this, terrible things were breaking down. You know, bereaved woman finally got her husband's bag back, but inside was someone else's teeth and someone else's slippers. It was just that level of chaos, and I could fill 3 hours just with stories like that. Big issue around DNR and critical care decisions, the way they were made, the way they were communicated, and the way they were communicated to both patients and families. And then a lot of problems because of denial of death rituals and mourning practices and restricted funerals, and not being able to go and visit people in the chapel arrest, etc. And all of this led to very extreme feelings of helplessness and powerlessness, and yet there was inadequate counselling and mental health support. People were being offered Zoom sessions, general Zoom sessions by crews, but nobody really had gone through the COVID bereavement. So there were real problems there. And what people have been left with, many people, is anger and blame and self-blame and a lot of quite serious indications of prolonged grief disorder. At the time, they also kept saying about the importance of the statutory public inquiry and the fear of it. And I think just today, with what's happened with the revelations over Hancock today, their fears were quite right. So overall, they were really keen to explain that COVID deaths are very different. There's people in society don't believe it exists. We had the anti-vaxxers, we had the people saying we should never have gone into lockdown, they were only old and sick anyway. So there was all this narrative as well that went on, that people were saying if you died of cancer, you don't have that. So there was a lot of issues, and they were the 11 global themes. But being sequestered, legal separation, if you like, that was the biggest problem, unable to get through anywhere, because people felt excluded at all stages. When the loved one first got sick, I've got stories of people trying to assess the parents over the phone or through windows because of lockdown, trying to work out how bad they are, to then go back and relate that to NHS 111. People about to get their coats when their husbands or fathers were being taken away in ambulances and being stopped, no matter how vulnerable they were. People being denied access while their relatives were dying in hospitals and care homes, and even at the point of death. This is about the research, not about me, but I phoned the hospital at 10 o'clock on the Sunday morning and asked, could we come and see Dad? We were told no. At 10 to 11, we got a phone call to say, come now. My sister's a police inspector, must have broke every speed camera and everything going. She got there in 12 minutes and she said, my dad's been dead for ages. That was the chaos, and that was the reality of what was going on, especially early on in lockdown. We weren't allowed to go to the chapel of rest. We weren't allowed to choose clothes or anything like that. We weren't allowed any of the social support systems, any wakes, any come together just for a hug, any funeral teas. We weren't even allowed any singing at the socially distanced funeral. They literally had bouncers on the funeral saying, don't touch the coffin, don't stand near the coffin, don't move that chair. That was the reality of what it was like. So important mourning rituals. And then, as I say, there were very few appropriate support services either. Just want to pick out a few little quotes to just give some idea around the themes we're going to talk about. Claire said, Mum and Dad needed to say goodbye to one another via video. We knew Dad was dying and Mum had tested positive for COVID herself. So they were trying to arrange a video call for these people who'd been married over 50 years to say goodbye. And the nurse said, well, we can't facilitate it just yet. We're doing a handover. And Sonal saying it was what COVID was doing to his body and them being separated. They're looking round. You can only see doctors and nurses and other people dying. And she's saying, I don't understand these rules. Surely, you know, one family member in PPE would have been a help to them. And this is what I'm talking about when I talk about really vulnerable people. Margaret's mum, she was 91. She was almost blind and she was deaf. 111 had said, take her in yourself because it'll be quicker than the ambulance. And this was the last conversation in the car park, because they were saying, no, you can't come in with her, even though if that's not the definition of vulnerable, I don't know what is. And Suzanne was saying, look, he's not taking his meds. Let me come in with a PPE. I'll get him to take his meds and I'll actually be an assistant to you. I'll help you, but they just weren't allowed. And there were examples of nurses actually breaking these laws, breaking these rules themselves. Pat, in 18 days, twice the same nurse helped her have a video call with her dad, and then said, please delete my number. I can get into trouble for doing this. And as Lynn said, if somebody drops down dead, it's a shock. But to actually know someone's fighting for their life and not be able to be there and will them on and be a support to them, it's a denial of really important roles. And people don't understand the trauma that causes you. And then access to information, it was a nightmare trying to get through to communicate with the hospital. 48 hours, 36 hours, these are normal, these were usual stories. Claire said 36 hours after Dad had been taken away in an ambulance, I had to email pals and say, can somebody please tell me what's going on with Dad? To and fro all the time. Please, can someone tell me? Suzanne's said Brendan got taken to hospital on Tuesday lunchtime and I didn't speak to a doctor until Friday. That is an awful long time to go with no information. And Pat said even when you could get through, you'd get a healthcare assistant. Oh yeah, he's had a bit of yogurt, he's had a bit of porridge. Nobody was actually given any information that was useful. Pat's dad got taken in because he'd had a stroke. He caught COVID while he was in there and he died because of the COVID. But she was saying things like, has he had a COVID test? And nobody was given her this information. And again, Lynn says, it's the trauma of not being able to get through, not being able to get any up-to-date information, phoning and phoning and phoning, and you just can't get through. And then when you could get through, there was very little consideration of families, no consultation with family, or even quite often the family not being aware that a DNR had been put on them. And this is a major issue that's coming out now. Stuart saying, I was frantically ringing the hospital to find out what's going on. The doctor tells me we've agreed to DNR because she's a heavy smoker, diabetic, and she's an asthmatic. She wasn't a smoker. She hadn't been for 15 years. She was an asthmatic. And they were doing tests for diabetes, but she wasn't even definitely a diabetic. And Lynn's mum had had a stroke a few years before and had a left side droop and would get confused. And the hospital phoned and said, right, we're doing scans. Lynn said, don't do scans. It's nothing to do. She's had this already, go back on her medical records, but they wouldn't listen. They did the scan. She said, how much do they cost? What a waste of resources. And then said, the clinicians wouldn't listen to us. We were actually trying to help. And yeah, we weren't being listened to at all. And this lady called Anne, who was a senior nurse. Why have you put a DNR on her? I know the assessment criteria. Oh, we're not telling you. So even somebody educated, even somebody who understood the criteria still couldn't understand what was going on and wasn't receiving any information about it. And because of that, this lack of power is really quite significant. People are struggling with survivor's guilt. They are blaming themselves. They are hoping that their families, their loved ones aren't blaming them. And they're also saying, why did we allow this? Why didn't we say, well, no, they're not going into hospital? Or when we heard, well, they're not getting a critical care bed, then why didn't we just go and get a taxi and get them out? Why did we allow them to just keep hold of people when they weren't being treated and they were going to die anyway? And so there are really big problems there for these issues. So I think overall we can say that this denial of access has had quite serious consequences on the bereaved, and there are clear indications of what we call complicated and prolonged grief disorder amongst many COVID bereaved. The frequency of pandemics is increasing. It used to be about every 10 years, and now look at SARS, MERS, Ebola, COVID, they are increasing. So we need better pandemic planning at all elements of society. I'm going to argue that pandemic planning needs better consideration of families. Communication channels need to be overhauled, not just for during pandemics. Enhanced use of digital channels, because I think that was really poor. And there needs to be recognition of the practicalities and limitations of current ICT, because it really did let a lot of people down. So thank you. And these are the 3 questions that you know about. From what I've just said, how can the NHS better harness technology, particularly to enhance communication between dying people and families? What can be done to improve communications between clinicians and families? And if we're going to talk about person-centered care, how does that include families and carers so that they're supported and involved in decision making? Thank you.
Thank you, Lynn. That was really clear and a very powerful message. We've got 3 minutes until we move to the next bit. So I wondered if anybody wanted to ask you, are you okay to take a question or two?
Yeah, of course. Yeah.
Has anybody got anything they want to ask, Lynn? And then we'll go into breakout rooms. Okay, no worries. Right, well, let's go to the next bit then. So what we're planning to do now, you've got those 3 questions, and don't worry if you haven't written them down. I think they were in the invite anyway, but we'll broadcast them into the breakout rooms so that you can see them. We'll put you into 3 groups, into breakout rooms. This bit, you don't actually get to choose which room you're going to go in, but you will have more choice after 1 o'clock as we go into the more participative second step. But it's just an opportunity for you to take those questions and engage for a few minutes with the question and bring whatever you think would be helpful into that conversation. So I think, Joe, you're set in the breakout rooms up. Are you okay? Is that all going all right? You're on mute, Joe.
Yeah, just bear with me while I just
Yeah, I'll just explain it a bit more then. So we're looking at 15 minutes for you to go into your group and discuss one of the 3 questions. It'll be pretty clear to you which question you're going to be focusing on. And then when we come back, just a few minutes for each group to give a little bit of feedback on what they've been discussing. So maybe helpful if while you're in the group, you can just decide which of you is going to feed back and have one of you just give a little bit of feedback to it. Perfect. Okay, so can somebody give some feedback for us from group 1? Who was in group 1?
We were group 3.
Okay, group 1 was Ahmed and
That was just me. We weren't really a group, it was just me really and Ahmed.
Yeah, thank you. What's your name, by the way? You've got
Lisa.
Lisa.
It's Lisa, yeah. So we talked about the technology. So I'm head of patient experience at the Walton Centre. I was just giving some examples of what we did during the lockdown process and during the visiting restrictions, because we didn't always get it right. And we offered, I mean, right at the beginning, we issued each ward. We've only got 6 wards, but it's each ward with 2 iPads. And then we were fortunate to, within about 9 months or 12 months, to be able to secure some monies to, and I purchased 3. They were 42-inch screens on wheels, so they were like huge iPads. So we could do virtual visiting in life size, but they weren't utilised enough or as much as they should have been. You know, often we'd find them stored down the end of the ward, or so they could have been. But I think that was due to because we didn't have any volunteers on site, because all our volunteers were isolating at home, because the majority of our volunteers have either got long-term conditions or brain injuries or are, you know, considered vulnerable. So we didn't have volunteers on site at that present time. We also supported with non-clinical staff, also supported with the virtual visiting with iPads. But again, patients didn't always get them as frequently as they could have or they should have. So I think probably going forward, we probably just need, all NHS probably need to have a business continuity plans to ensure that if that does ever happen again, that everything's there and everything's ready to go. Because it took some time getting the equipment to the places and getting staff trained up on how to use them.
Brilliant, thank you. Ahmed, did you want to add anything to that?
Yeah, thanks, Stuart. So we were discussing sort of links as well, weren't we, Lisa, with other charities. So I know you were telling me like you work very closely with the Brain charity, who provided support, and they're on site now, and that there wasn't any obviously volunteers on site during COVID. So in terms of like lessons learned going forward, maybe the volunteering aspect is also something to think about more carefully. And Lisa, you also mentioned that you're moving towards the SWAN model of care, aren't you? Yep.
Yeah, towards for our end of life care, we are moving towards, well, we've got a business case in progress at the moment. We work in partnership with Luft, so Aintree Hospital, and we work closely with the bereavement and end of life team. So we are putting plans in place to adapt the SWAN model of care for end of life. So hopefully that will improve the experiences of our families going forward.
Brilliant. Okay, thank you. Thanks, both of you. If we move to room 2, so in room 2 was Ben, Heather, Lucienne, and Lynn in Sudbury Riley.
Oops. I think we were 3, weren't we?
Yeah, we were 3.
Uh-oh.
Oh, don't worry. Just give us some feedback anyway. We may have had
We got the third question flash up, so we answered that.
No worries. Whatever happens is what happens. So do you want to answer that question, and then we'll see whether yours was as good as room 3's.
It's competition now, Lynn. No pressure. We're ready for you.
Oh, sorry. Okay, well, we talked about culture and the NHS culture, and we said this isn't a quick fix. And we got onto the difference between hospice end-of-life care and NHS end-of-life care. And we know that in a hospice, it really is patient-centred and person-centred. And it's all around the people and the families. They are a crucial stakeholder and a crucial consideration for end-of-life care in hospices. Whereas we said with end-of-life care planning in the NHS, they're not very good at it, we didn't think. They're very much about cure, and they don't really know what to do when there is no cure. And too many sort of trainee staff aren't really equipped to deal with end-of-life care. We found, I ended up talking about wider projects that I've done with AMO and with PIPA into end-of-life care and the differences between what goes on in hospitals and what goes on in hospices. And I think, you know, you've just been talking about iPads on wards. I know of other people, and I did this myself. We sent a phone and an iPad in for Dad, but my dad was a bit deaf. Didn't matter how many times we phoned that phone or rang that iPad, nobody was ever there to answer it or to even tell him it was ringing behind him. Supermarket staff were counted as key workers. They were allowed to go to work and serve people with tins of beans. But volunteers wearing PPE, I'm not talking about the ones who were shielding themselves. There were plenty of people who had been furloughed who would have willingly donned PPE to man iPads and phones in wards, but that wasn't allowed. But you were allowed to go into work and serve for tins of beans. And to me, that's where the priorities were all wrong.
Yeah.
Well, one thing that Lynn did say was when they're in hospitals, the families are just made out to be a nuisance. And that was a really good point, because obviously I've experienced hospital treatment and hospice treatment, and the difference is unbelievable. And yeah, that's right. Families do come across as a nuisance. But like when Lynn was saying, when they sent the lady for the MRI scans and things that she didn't need, the family knew she didn't need that. But we were saying about the time in the hospitals that the nurses have got to read up on the notes. Do they actually read the notes? Do they actually know what's gone on beforehand? Or are they just interested in there and then and what they can see? So we were saying paperwork in hospitals takes up a lot of time rather than giving the patients and the family or families the care that they actually need.
Thank you, Heather. Thank you. Any more comments from that group? Okay, shall we move on to the third group then, which was Amanda,
Julie and Bernadette and Kate. So we had a really good group. Thank you for your contributions to the conversation, and some really very insightful comments from our group around the recognition that potentially communication isn't really the best it could be within the care settings generally. So there's an acceptance and a recognition that when your situation deteriorates and you become involved in a pandemic situation, what potentially isn't good already deteriorates, and the communication elements of working and sharing information between families and patients and professionals did suffer under the pandemic situation. The pandemic in our group's view did make the communication issues a lot worse than they had been. Real live examples of where problems occurred with equipment, for example, when particularly people who are hard of hearing were trying to get information about patients, and they couldn't get the professionals to wear the see-through visors, and they would wear face masks so they couldn't lip read. Real issues around the suitability and the methods of communication. We talked a little bit as well around email, because a lot of the time those direct conversations that would normally take place within a live setting, and people would be able to read body language and be empathetic, suddenly were taking place in writing, and there was a lot of technical language and terminology that people really didn't understand, which caused, again, incredibly difficult and almost impossible situations to try and share information around care and make decisions about care for both patients and their families. What was important, I think, from our group's perspective is that some areas have been identified for improvement, and I'll focus on what that was Julie's thoughts, were the first thoughts that we had, and Bernadette came very closely behind that with some really helpful comments around what they've been looking at to try and improve these things. Overall, there's a general acceptance that everybody wants people to receive good care and want to involve patients and families where possible in decisions about care. Bernadette was saying from her perspective, we need to communicate much earlier in the disease process with families. That's professionals to families and to potentially patients as well. So those discussions around the condition that people have and the care packages that might need to be in place and the treatment programs that are going to be there need to start much, much earlier. Care planning in the whole needs to start a lot earlier, almost from somebody's admission to a care setting. Bernadette had a really good point about there is documentation enabling people to document decisions about care, and therefore we need to make that much, much more simple and clearer and easier to complete, so that it can't be misinterpreted or put to one side because it's too complicated to try and understand. Very interesting point from Bernadette is that nobody likes to have those difficult discussions, and often it's not just us as people hearing bad news that want to try and step away from that bad news or avoid it, but professionals don't like to have those discussions either. So there's a potential there maybe to provide more support for professionals and more training to professionals to enable them to have those difficult discussions a lot earlier on with families and with patients. And that was under the heading of sort of empowering people to talk. In recognition of everybody was thrown into COVID and nobody was prepared for it, and there was a general feeling of everybody was learning as they went along, and a total recognition that some professional groups got engaged and got involved in it, and others stepped away. And I think one of the examples we got was the GPs stepping away from involvement in the care home situation, which is very topical at the moment. It's that recognition as well that it wasn't just individuals coming into the hospital, but NHS colleagues lost colleagues and peers too through COVID. And so you had suffering not just for families and those who were patients in the hospital, but also managing that situation whereby people were losing potentially their colleagues and their peers and their co-workers. And basically, it is incredibly challenging. this type of situation. And I think there's just a general recognition that anything that can be identified to help this be done better is what's needed. Yeah.
Brilliant. Thank you, Amanda. Those 3 sets of feedback give me an indication that there was really rich discussion going on in those breakout rooms. So thank you. And that was very clear feedback from each of you. So brilliant. Thank you for that. Ben, I think you put a comment in the chat. I think you had to take a time out for a call and then come back. Did you want to articulate that comment now? Did you want a moment to say?
Thank you. Yeah, so I don't know whether I missed anything in the conversation. I've got to go in a minute because I've got a PhD student's presentation, but I'll try and join a little bit later this afternoon. So I'm sorry if this is repeating what's already been said, but I think there's a real issue around training that's available, and my understanding is there is not a huge amount of training for nurses, doctors, and other healthcare professionals around end of life, death, dying, and bereavement. And so the first time that those professionals encounter death is often either when it happens on a placement or when it happens as part of their job. And so I think there's sometimes a lack of preparedness for those situations. And just picking up as well something that Amanda just said around language and terminology and research that I've conducted, is where parents and young people have actually said they're excluded from conversations because of the complex nature of terminology and of language. And so I think the way that people communicate with each other and actually involve people in decisions, because my PhD and some research since has been around advanced care planning, and those people actually said they wanted to be involved in the decisions, they wanted to be involved in the processes, they wanted to be involved in those discussions, but they often feel excluded. And I think there are a number of reasons for it, but one of those reasons, as Amanda sort of said in her feedback, is around that language and the terminology, which is not everyone understands it. So I just wanted to raise those. So thanks very much. So I've got to nip out now, but hopefully I'll be back a little bit later. Thank you.
I'm glad we brought you in, Ben. Thank you for that. Appreciate it. We'll take a pause now. We'll have a break anyway. So I can suggest we break for until 10 past. It's just 2 minutes past 1 on my laptop here. So if we break until 10 past 1, please stay connected. If you just want to switch your videos off and mute yourself, and it's a chance for you to grab a cup of tea or whatever your drink of preference is, and we'll see you back at 10 past. Thank you. Those of you that are here, it's great you've managed to join us. Our numbers are small, so the process and structure, some of you may have heard us talking in the break there, but we had a structure that we had designed for this that we need to not use because I don't think it'll work. So I'll take a minute to tell you what you're missing, which was we were going to have a session of about 10 minutes now where I would have explained a process of open space that we were going to use, and then we would have set an agenda, maybe 6 to 8 different topics, and broke you up into breakout rooms to go and discuss that. Any of you with basic mathematical skills will know that that would have put you in groups of 1 or 2, so probably not a good idea. So I'm going to suggest a different approach. We've got just under an hour, and I'm suggesting instead in that time that we treat this as a group. I think most of you have had a chance to talk and air your voice already anyway, so please don't be shy. You've, apart from 1 or 2, if you have heard the first half. If you haven't heard the first half, I'm hoping you've seen the film anyway, so you've got the essence of Lynn's research. I'm going to open this now into a facilitated discussion. So my suggestion, and we can go off piste, we can go do things differently. This is your session now to work with as you want. I'm going to suggest a few things. I'm guessing some of you come here with your own research agendas, your own research ideas. You might want to spend a little bit of time talking about how they connect to the work of today. Some of you may have lived experiences that you might want to bring into the conversation in the time that we've got. And some of you may just be really interested in asking a little bit more about Lynn's work. So I'm going to make it that open a space. The space is yours to use as you would like. I'll facilitate and make sure we don't all talk over each other. If anybody wants to talk, they raise their hand. And I may kind of draw things to a close if we feel like we're spending quite a long time on one topic. I've seen you handling. That's my suggestion. Lynn's probably got a far better one. Lynn, what did you want to say?
No, it's not. It's just if we're opening it up, there was just two things that worried me a little bit on the feedback from Amanda's group, and I just wanted to come in. Is that okay?
Absolutely, yes.
I was going to try and come in before. One of it was about the pandemic and we weren't prepared, and I think that's one thing is that we need to make sure that can never be said again. And you say, but that's not just the NHS and everybody else really, and every other facet of society. If you look at the government, the major risk to this country was a flu-like pandemic. Not terrorism, not a tsunami or flooding, or a flu-like pandemic. And the government knew that, and yet we weren't prepared. So I think that's something that we need to make sure can never be said again. The other thing was I didn't want to ever come across as not being concerned about frontline nurses. We know they were losing staff themselves. My very best friend, I was saying this in my group, was moved from being a theatre sister to frontline COVID. She's got PTSD. She's in a right old state. So, and she lost a colleague who she'd worked with for a long time in injury. So, but that's a different research study as well. And I also think that some of the trauma that some of those frontline nurses have experienced were also because they were on their own without the support of families. Does that, because she said we were trying to be the family as well. Yeah. So they're interlinked and overlapping, but I just wanted to make sure that nobody thought we weren't, because nobody was blaming these frontline staff. You know, not at all. They did their best. Thank you.
Thank you. Okay, so the floor's open. Who would like to speak first? Pippa.
Hi. So whilst I haven't disappeared, I thought it'd be wise to start. One of the things, you know, Lynn's just mentioned, you know, this preparedness, and this, you know, we know broadly, we have a sense that a flu-like pandemic, you know, these things we're out there potentially, and we have, you know, other potential bird flu, whatever, moving forward as well. So it's not disappeared, has it? It's still there. I suppose for me, it's the pragmatic, practical things that, you know, what can we learn from and move forward with? So, for instance, you know, if we take the technology question, the iPads, etc., how can we make sure that is in the business plan, there is business continuity that prioritizes that in the actions of a hospital, hospice, whatever environment. So because there is a sense that it falls between, is it nursing, is it volunteers, and volunteers aren't there, so it falls to nobody, you know, and who has ownership of something that is non-clinical, but in situations like this are fundamentally massively important, because it's that practical bit of what can we do to make that difference moving forward. Okay, that I'm fascinated by that, because I don't really have a sense at the moment that anybody has ownership of that, you know, because clinicians are trying to keep people alive, nursing staff are trying to keep people alive and supported. So where does this bit? I was just to sort of go on a little bit on this same topic, and it was communication was being raised, but interrelated to this, one of our colleagues, I'm really minded by something he said. He said, I know where my Amazon parcel is at any moment. I can look online and I can see it's 6 minutes away. It's being dropped off by Adam. Adam drops off around the country, so I think that's a made up name. But, you know, I can see where this is happening, but I can't see where my family is in a hospital. I can't communicate with them. I can communicate with Amazon, a massive organization. So I suppose I feel, and there's something missing here. That it's not a clinician, it's nursing consultants, whatever. It's not that bit. Whose bit is it? And how can we bottom that bit out for there to be a practical way forward? That's just I don't have any answers, sorry, Stuart. I'm fascinated by it.
I'm wondering if anybody on the call either has the answer or would like to talk to that and respond to that point. Yeah, Jackie.
Sorry, I'm just getting myself familiar with Zoom because I'm always on
I'm
Microsoft
happy
Teams.
with hand waves like this,
Oh.
right? By the way, if you
It's
can't
fine.
find
I've got my buttons. I've got
digital
my
hand.
buttons now. I can unmute
Perfect.
and raise a hand, so that's good. So I'm sorry I was late. I'm Jackie Brunton. I'm the lead nurse for End of Life and Bereavement Care. I for my organisation at Blackpool Teaching Hospitals, which covers the hospital and the community, we didn't have a bereavement service and support team at the time the pandemic hit, and my role was cancer lead nurse and end of life. So I was tasked with bringing together a team, so a family liaison, a support team, a bereavement team. So very much responding to things as they happened. So we weren't fortunate to have that infrastructure, so we led a reactionary service, and it had everything in it, from trying to support families with digital technology, suddenly getting iPads and iPhones in place and supporting those conversations and being there for families in that way, and supporting staff who were going through that front line, the trauma at the time of not having people there trying to support them through that. So probably got lots to say, and I just wanted to echo everything you've just said around how do we take this and know that there is some legacy. So my important thing from this is that we can't change some of what has happened. It'll be always difficult for us to live with it because it's not in our core of how us as nurses, doctors, etc., would ever have envisaged us not having families with patients and with us. There is still, for many, many years, going to be the after effects for staff and people that are affected, as well as bereaved, and also families who now we're seeing have been through bereavement during that time, but now are in the same situation, and we can see the impact to them in a complex grief, because it's bringing back things. So I do feel really strongly that there are things that we can really support and champion, and it becomes part of a recommendations for national agenda. So it's finding really firm places to make recommendations about. So you've just talked about sustainability and whose responsibility it is, and that's finding a place that it's strongly and firmly recommended that the digital agenda and keep continuing to speed up the pace of our digital access. So we should be able to see a loved one in hospital. We should be able to visit them digitally every day, not just because they're dying. And there should be that communication there without having a Hospedia telephone. I mean, don't need to use a company's name, but without using a telephone service that you pay for. Most people do have mobiles and they do have that technology, but not everybody does still. One of the things that I feel, again, we need to strongly lobby for and find those routes, and it is being addressed through an all parliamentary group in government, but bereavement support being equitable and accessible. So we didn't have it at Blackpool. I'm really proud we have it now, but we still have gaps. So we still have gaps around children's services and things. So I'd like to see that kind of really strong, that people should be supported, you know, at end of life and into bereavement. And the other thing that I feel can be continued to be worked on, and there are a lot of people doing this, really high profile. So Catherine Mannix and the Good Grief Trust, is we talk and we continue to talk about death and dying openly, so people can have conversations and to know where to seek out support. So they're my three go-to things that I find. If anything can be done through this research and continuing that voice or continuing research, I'd love to be involved in and support.
Thank you, Jackie. And actually, you've raised an important point there that I should have mentioned at the start. This is the beginning of a dialogue potentially for you. There's an opportunity for you to stay connected with Lynn if Lynn's up for that, and to kind of start to open up some conversations here that will flow out of today. So thank you, and thank you for those points. Bernadette, you wanted to go next?
Yeah, I suppose I just want to echo a lot of what Jackie said there, because we're probably in very similar roles in neighbouring trusts. And probably what will come across from the both of us is our passion, our absolute passion for that this should be the gold standard. But sadly, that's the reality of not. Somebody was saying earlier on about hospice care and how, you know, how wonderful hospice care is in comparison to the NHS. I've been both a hospice nurse and an NHS nurse, and I suppose just to put some perspective on it, only 4% of people die in a hospice in comparison if you think to the amount of people in the NHS setting. So you can provide that gold standard care, absolutely you can. And it's a charitable organisation, most of them. So they, although they're struggling, they do have those money to focus on that. I'm not here to make excuses at all. I suppose I'm just highlighting what the difficulties that we face. And very much like Jackie, coming from that background where we know the importance of it. In East Lancashire, we again, it wasn't there during the pandemic. We didn't have an end of life and bereavement service. We've only just got it in the last 12 months. And we know how important that is. And you get these things after you go through a rigorous processes of delivering business cases, justifying it. You know, that probably took a 12, 18-month process to do that. And during that time, you know that there are patients and families out there who desperately need your support. All we had available during COVID was a specialist palliative care service, which provided a 5-day week service. It didn't work 7 days a week. And again, we've had to put a business case in for that. I've worked in other areas where in 2010 introduced a 7-day service, and you know the absolute benefits of it. That patients and carers get, but you've got these constraints in the NHS and the hoops that you have to jump through. So as I say, I think you can hear Jackie's mind, passion, and how we're desperate to improve services, and we will carry on that fight to do that. And like you say, this is great that you've got this today to do that and support us, because that's what we need. But please be assured, for those of us in local trusts, that we are working very hard, striving very hard to ensure that this is on both the local and the national agenda, and we welcome any support. And I'll have to apologise because I need to leave very shortly for another an urgent meeting, and sadly that's the reality sort of the health service. It's just bang, there's been no respite following COVID. It's still, you know, bang, 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 but we are desperate and passionate to improve things for people. So happily to be involved in anything, and as I say, I'll have to leave shortly. Thank you.
Thank you, Bernadette. Thank you for that. There's some really rich content in what you said there. And you talked to the point, we used to run these events in physical space pre-COVID, and we ran all-day events. That luxury is long gone. We did them as half-day events. We really struggled with that as well. We're down to 2.25 hours and still struggling to get people free up to the time. So yeah, it's something we need to continue to think about how best to get the engagement. But thank you, that was very valuable. Please feel free to leave when you need to. Pippa.
Yeah, just to follow up and say thank you so much. The passion certainly comes through, and certainly having done the research in the hospice sector and hospital environments, you know, it's understandable that there are sort of differences between the two for many reasons. I think also, in all honesty, hospices have more of the control over their decision making. I think fundamentally that's the difference, if I'm honest, because the processes are so much more straightforward. Hospitals can take years, can't they, to actually achieve something, which actually takes me into just, I suppose, like my question still is, making very strong business cases and moving forward that route. And that takes years to achieve or months to achieve, whatever, absolutely understand. But where does it fit? Who makes the business case when it comes to that communication? And the reason I ask that is because I am a governor at one of the hospitals in Liverpool, and I know the marketing and comms team do a lot of the internal and external communications, but they don't pick up things like this. And I'm not aware of anybody on the clinician point of the side of things who are making business cases here. So that's my practical head.
Mm. Amanda, and then Bernadette. Bernadette, Amanda, do you mind if Bernadette goes first? As she needs
No,
to?
not at all.
Bernadette. Yeah.
Sorry, I was talking with you, being muted, wasn't it? Again, for those people within the NHS, and as I say, I've worked in both and thoroughly enjoyed working in both. The business case, so we had an initial bereavement business case that was written by a clinician and didn't have any support from, we have a business arm. The second business case that was written there was some support from the business arm, because at the end of the day, we're clinicians. I have no expertise whatsoever in business. It's not my background, and I run away from numbers because I was rubbish at maths at school. However, so it has got better. It has got better, but again, you'll be very aware of the financial constraints in the NHS, and now obviously we're having to pay for COVID as well. So it's absolutely clamped down, and we've been successful in ensuring our last two remaining business cases were approved, but that was out of quite a significant number. So thankfully our trust did recognise the importance of it at the expense of some other service as well. So there is support there. It is limited, and often clinicians are left driving things when it's not their expertise. So I just wanted to give some context around that. Thank you. And I really will have to leave now, but it's been a really great session. Thank you ever so much.
Thank you. Thanks for that. Amanda next, and then I've seen you, Jackie. You're after that.
Yeah, thank you, Stuart. Just I'll put my other hat on, Pippa, because I might be able to help with some of this. How do the decision-making things happen? Because that's my background before I joined NHS R&D Northwest, was I sat in that space. So I can sort of share with you a little bit about the process and how flawed it is. And I think for me, it very much ties to what Lynn has been saying all along around emergency planning. These things, as Lynn has quite clearly enunciated, they don't come out of the blue. We know we've got these massive risks as an organisation, as an NHS trust. We know there's got massive risks potentially barreling down the line all the time onto frontline services. So from that perspective, within a trust or within a department of health, or however you want to sort of call that structure, you have a team of clinicians who sit up there on the management team, and you have what you would say are public sector workers who are there to do their sort of their governance element of it, and to run the backroom services like comms and marketing and HR and finance elements of a health service. And those people are allegedly supposed to come together with their board of their trustees, and they make decisions. The trusts are allocated a budget. They know what they have to do with that money. They know how much has to go to frontline services. They know how much potentially they've got for development work, which may come around some elements for the business cases that people or new services people want to explore and put in place. And then you go into this almost a dragon's den process. But what Bernadette was interestingly saying was, who leads the business case development for these things? And the answer is only a clinician with a lot of passion for it. And therefore, if you don't have somebody who has either capacity or passion to drive that business case to the point where it's getting to people who can make decisions about funding, it's likely to stall. But there's also a big issue for me is the paperwork that you have to complete to start a new service or a developmental service within the NHS is horrific. So how those business cases ever get from frontline, where you absolutely know it's needed, to a decision to put funding behind it, that network of hurdles and hoops that you have to jump through and go round is just incredibly difficult. So any new innovations that come through are really hard fought for and hard won. So, you know, all sort of support and praise for those people who take them to that delivery point. I'm just very interested from another perspective, which was when you have an emergency situation in something like the police force, for example, you have a system of, don't you, bronze, silver and gold command who suddenly leap into action to manage that. And around that is wrapped a very, very small group of people who can make decisions. They can make decisions about resourcing, they can make decisions about spend, and they can act and react very, very quickly to situations such as emergency situations. All of that is documented. And that, you know, we've seen many police inquiries when things go and they unpick why decisions were made the way they were doing at the time, and things happen. But it would be great to think that NHS trusts could have something like that, and maybe the inquiry would say, right, you know, if we hit a pandemic or a crisis situation again, we go into this particular model where decision makers can make decisions, and they're a balance of clinicians and the people who hold the money or hold the resource, and we can get things done in the patient's voice, and the services become key to that. And that could be a way forward, is to try and get that model adapted, or a model similar to that. So I hope that's helped, Pippa, but that's just a couple of things that I've been thinking about around the structures there.
Thanks, Amanda. I'm going to go to Jackie. Oh, thanks for the thumbs up there, Pippa. And I think I saw your hand, Julie, so I'll come to you next. And no pressure, Lisa, but if you wanted to speak, I'll give you a chance to talk then as well. So, Jackie.
So yeah, I'll just kind of talk how practically that worked for us, because things happened for us in response to COVID. So a lot of the barriers that were there, we were just unable to redeploy people. I was able to be freed up to do that, but obviously a business case followed. So one of the things that I will say is that it was a clinically led process. So I was leading that with a consultant. So we did lead it. We were supported by our workforce and business partners to develop the business case. So that engagement was critical. And the other side of that was that we do have, and all provider organisations should have, an end of life executive lead. Our end of life lead was the director of nursing, who was fairly new to the trust at that time, but was very, very engaged and supportive, and end of life care was very much an important area. So I had no concern that I had an exec lead that was supporting and taking that business case when it was presented, and representing it at a board level. So I'd say those engagement and them involved in that process. I think the other thing was key is that as a filed coast, we have a very long-standing end-of-life partnership group. So all of partners, the hospice, are what was CCG, now our ICBs, all providers are on part of a strategic group. So we have a file coast strategy with priorities, and they kind of link into our governance processes. So we have a voice and we use it, but it's the clinical leadership and having interest. Prior to COVID, in a previous time in the same place with a different board and priorities, I had put several business cases through, and they'd not been successful. So I think there are things, as you say, if you've just alluded to there, and that's me.
Thank you for that. Thank you, Julie.
Well, kind of leading on from that, really. I mean, as we broke out, I explained that I'm a palliative care nurse with a community heart failure service. So I'm very much on board with Jackie and Bernadette here. It is often a case of who shouts loudest, and you're up against some very, in inverted commas, sexy new treatments that are going to do all sorts of things to make the world a better place. And often you don't win these battles when it comes to business cases for end of life and palliative care. We're in a very different place from when I first started 20 odd years ago in different aspects of palliative care, but we're having the same problems in in a different way. And I just feel that we're seemed viewed as a very specialist workforce in end of life care, which we are, and palliative care we are. But actually, death and dying is everybody's business. It doesn't matter if you're a critical care nurse, a neonatal nurse, A&E, wherever you go as a nurse, a physio, a doctor, or whatever, you will come across death. And it doesn't sit in the education of our nurses, our doctors, and I guess any other professionals, where it should do in their training as a normal everyday aspect of your day-to-day work. Is you will meet dying people and bereaved people, be that in a acute setting and it's a sudden death, or be it an expected death. My son's a medical student and he's about to qualify, so we're 5 years in, and I'm staggered how little input from death and dying he's actually had. And they sit this progress test every year, and when he comes out and I say, and how many death and dying questions did you get this time? Well, 1 out of about 400 questions or whatever, and it's probably how to titrate morphine, and it's absolutely nothing to do with how to communicate. Yet he hits the wards in August and is expected to cope, and it's much bigger than what we're saying today. But the problems that people have had are as a result of poor education and thinking it's somebody else's business. Oh, this person's not well, so I don't have to talk to them about that. I'll just call the palliative care team. Well, actually, you do. You need to explain why you're calling the palliative care team. And you walk into situations where people haven't got a clue that that's what's going on. So it's far, far deeper than it ought to be. But unfortunately, we haven't responded as nurses, doctors, etc., to the needs of our patients and their families in a very good way, really.
Thank you, Julie. Each of you are giving such powerful messages, and they're kind of heartfelt and bring a passion with them because they're personal to you. They're your own experiences. Lynn, did you want to come in? You're muted.
I just wanted to echo that from our wider research, and Pippa and Emma will tell you this, how often new nurses, new doctors have had no training, and they're floundering and they're out of their comfort zone. And as you say, it's the most natural thing to everybody, and yet the taboo, if you like, and you expect the taboo in society, but it's there with clinicians as well. And I just think that's like a fundamental shift is needed in education and training, and it's not a quick fix. That
No.
Just a comment, to say, yeah, absolutely, I know where that's coming from.
Thank you, Lynn. I think I've been calling you Ahmed. Amo is better, is it? Shall I call you Amo?
That's thank you, Stuart. Your pronunciation of my first name is fantastic. Thank you for that.
You.
So just to follow on really from Lynn, in terms of education, is this something that we need to advocate from the grassroots level? Because if we think about trust, right? So trust is the Achilles heel of almost any crisis response. So we think about, now if, say, another crisis hit tomorrow, be it COVID 5.0, for example. So what's that trust going to look like in light of, what's happened already? Because the majority, as Lynn so aptly covered in the presentation, were following the rules. And the anecdote that you shared, Lynn, about the nurse whose mum, I think, had COVID, she was at home and she was talking to her through the window. So if COVID 5.0 hits again tomorrow, what's that level of trust going to be like? So I think the trust issue is a really important one to take forward.
Lynn, yes. Yeah.
Do you know what, Amo? I would be petrified if it happened again, because I know for a fact the 220,000 odd families of the bereaved, there's no way they'd go through that again. No way. There's no way, like I've got a disabled son, and MenCap said, you know, anybody coming in with disabilities like that, we're getting DNRs slapped on them. It doesn't matter how many policemen you threaten me with, he's not staying in hospital if that happened again. Until you do arrest me and drag me out. And that is repeated so many times. And I think that's a real problem. And that's not about the NHS, that was about the government. And look what's happened today. Even while we're online now, I'm knocking back BBC interviews because of what's coming out today with Hancock. It's just,
yeah.
And the trust has gone. And it's a real problem. Yeah, real problem.
I'll get us away a little early so that you can pick up the BBC interviews. I think it's important you do that. Who wants to speak next? Shouldn't have said that, should I? Everybody's thinking, oh, right, okay, we'll leave it there then. Please, if there is anything else anybody wants to say, this is your chance. Otherwise, we'll conclusion now. Ben's just rejoining, so good job we're still here. Hi again, Ben. Hello. Hi, Ben. Welcome back. We've just kind of run out of steam a little bit. I'm just giving a pause for a minute to see if anybody wants to make another point. Okay. Maybe it's time to wind up. I think that the time we've just spent since the break, that conversation was, I personally feel, really powerful. Thank you for all your contributions. Thank you for the provocations from the academics in the space, and thank you for the clinicians who spoke so passionately about their own experiences and gave us some practical descriptions of what's going on for them at local level as well. I wonder if we could just take a few minutes to just go around the room and give each of you an opportunity to just give us a few words by way of a checkout. Perhaps I can ask you two very simple questions. How are you leaving? And what are you taking with you from this conversation? I'll go around my screen. So I'll start at the bottom. I'll start with Ben, and then we'll go up the screen. Ben, how are you leaving, and what are you taking away? You've only just come back in. Sorry.
I've only just joined back. But what I took from before I went, which I think for me has kind of been a bit of an under ripple in research anyway, is just hearing people's voices, hearing people's lost voices, and those people who aren't ordinarily included in research, to actually include them and to use those voices to make a difference. Because I feel that there's without wanting to get too political and too controversial, there's kind of like this hierarchy in society, and it's trying to use those voices to break through that and to get those people at the top to listen and to change and to make the world a better place. So I've only just joined back, so it might not have fitted into anything you've been talking about in the last half hour or so, but that's what I got. That's what I got from watching the video. And from being in the first part of the session today. That very much fitted in with where we've been since you left. So thank you for that. And thank you for bringing a little bit of politics into this. I think that's important. Jackie, can I ask you the same questions?
Yeah, again, it's just, well, thank you for bringing those voices, and they're heard, and that they continue. I hope that we continue to hear that, but also it's to just commit really to everything that that people have said, is that we want to continue to make sure perhaps some of the things that we've learned from that we wouldn't want to do again, but that we continue to make that commitment to people, and to continue to make things better, so people do feel supported. And so yeah, I'm offering my personal commitment, my team's commitment, and to anything, I welcome keeping in touch.
Thank you, Jackie. Julie?
Was forget to unmute. Sorry. No, I really enjoyed reading the research paper. I read it after it come through a couple of days ago, and listening to people today. And I do think, having read it, we do have a duty to those 30 people who went through a very difficult conversations to bring to us what their thoughts are and where we could improve, that we therefore must improve. And I've certainly spoken to, within my trust, to people today about bringing the topics from today to their attention. And it was at a meeting I was at this morning, one of the rehabilitation wards has again closed to visitors because of COVID. And the ward sister was talking about, you know, how hard that is to have people in hospital long term who can't have that connection with their families and things, and what we may be able to do. It hasn't gone away. It's gone away as a massive problem, but we're still on a day-to-day basis on the front line having problems with COVID and wards closing and stopping and visiting. And I hope to take a few things and thoughts forward from this to try and help in that situation. And I thank you for the opportunity to be able to do that. And I thank the families for giving their time to enable us to know how they were feeling.
Thank you, Julie. Thank you. Lisa, I think it's Lisa, isn't it? Have I got that right? Yeah.
Thanks. I would say, you know, it just the passion and the compassion just comes straight through from everybody today. But I feel like we just need to continue to learn, and in my role in the trust as well, the importance of using not just patient experience but lived experiences of people in everything we do from the beginning, not you know, halfway through processes, or we need to start with that. So, thank you.
Thank you. Thanks, Lisa. Amo?
Thanks, Stuart. A myriad of emotions, I think. You know, I think absolutely inspired by the incredible work that Lynn has done, but really angry, I would say, at the same time, but also hopeful in terms of changes that can be done going forward. I think, you know, without getting too political, one has to question the use of you know, the pop-up centers that we used, or not used, should we say, like the Nightingale suites and so on. And perhaps if there was another crisis, well, maybe that funding could be redirected elsewhere. Maybe there could be other, I don't know, localized pop-up units to support hospitals, and so on. I'm just, you know, throwing ideas out there, really. But yeah, I think there's a lot that we've learned. There's a lot to be learned. I think an early response is key. Look at Japan, for example, because, you know, we look to other international countries to learn from failings here. So they use the Sanmitsu approach, where they use the 3 C's, where they encourage citizens very early on to avoid close spaces, crowded spaces, close contact settings. So that would form, I guess, part of the response strategy should another crisis hit.
Okay, thank you. Thanks. Kate?
Yeah, it's hard to summarize what I'm thinking and feeling at the moment, because there's so many things going through my head. One is that I feel very naive. So I don't work as a clinician, I don't work in a hospital, and some of the things I've heard today, I can't help but think, but surely you had that, but surely that could have been sorted out, you know, just as like a citizen, as a member of the public with very little knowledge of the goings on, I suppose, in a clinical space. I just kind of struck by my own kind of greenness in relation to that. Something else that struck me, I think maybe was what Julie had said in one of our breakout rooms, which was the absence of human touch and the context of empathy and compassion, which gets stripped away in these circumstances in which, understandably so, people at the front line are having to make such difficult decisions about what to do in a climate of fear, a lack of knowledge about this virus, but how important they are, and that they're not luxuries or add-ons or trivial, you know, those things that we think of that provide that kind of human touch, that familial environment, that sense of familiarity and comfort. Strip those away and you lost a massive part of the care that you're providing. I think that's what really struck me in a conversation, that we had earlier. But I just wanted to say thank you as well. It was such a privilege to hear everyone's accounts and different perspectives on it. I think this is an absolutely fascinating and ultimately necessary piece of work that needs to be continued. Thank you.
Thanks, Kate. Thank you. Jo?
Very similar thoughts to Kate, really, because I'm non-patient facing when it comes to clinical work. I think, again, the naivety of, while I sit here in the comfort of my little office at home, you don't realise that the people on the front line are still battling this. You know, life moves on, and, you know, we've all moved on as a team, and, you know, we all remember 3 years ago saying, oh, we're going to have to go home for a few weeks, and never thinking that 3 years later I'd never go back to that office again in Manchester. And yeah, I think it's just the reality's hit that this is still a real issue for people out there on the front line who are having to deal with this day to day, even from the people who've been on the call today who've had to dip out because things have happened. And I think, again, it's that reality that this is still around. And I've watched Lynn's film 3 or 4 times now, and I think every time I watch it, it stirs up different emotions every time. And just, again, echoing what Kate said, just a massive thank you to everybody who's done everything that they've done and they're continuing to do.
Thank you. Thank you. Amanda?
Yeah, thank you for that. I mean, it's been a great session, and like everybody, I got lots of hope, actually, seeing Lynn's research. I think she's really brought that people's lived experience to the focus of so many others, and it's such a powerful piece of work, Lynn. So well done for doing all that you've done there to get that message over. For me, I think what I've learned today, listening to my colleagues, is around the power of communication, and language is so important, and how we as a race communicate with each other and share our feelings and our thoughts. So interested to hear about the lack of training and awareness for people, so particularly, you know, doctors coming through, Judy, from what you've been saying about the questions and the areas that they get explored with the end of life care, and the conversations that they need to be better equipped to have, and the engagements they need to be better equipped to have. I think, Lynn, there's been lots of material today that could really help with, you know, being focused on training for people who are working in the care setting, around having those difficult conversations and early end of life care planning and sort of things like that. So there's so much wealth that's been shared today. It's where do you start? And I hope we have helped to keep the conversation going.
Yeah, thank you. Heather?
Lynn, have you showed that video to Matt Hancock? That video it's very touching, very emotional, and it's real, and it's real people. So I feel quite emotional. I have watched it before today. I feel quite emotional watching that, and the work that you've put into it, Lynn, is amazing. And probably on behalf of everybody, thank you very much for that. Obviously, you suffered with losing your dad during COVID, and there's probably other people on here that have suffered as well. What I feel is that I wouldn't want to go through, it stands out the most for me, is I wouldn't want to go through not being able to be with a loved one at that time. It is so important, not only for us, but for them as well. And if there was anything that could happen so that didn't happen again, if we had another major pandemic like that. I know it is still going on, as it's been said, some wards are closing visitors, and I don't like that. That is just really sad, and people need that support, and especially at the end of life, anytime really. But I just want to say, whatever can be done, if there's anything that I can do to help, I would be happy to do it. But just really well done, Lynn, and I'm sure that you you know, you've got the backing of lots of people as well to help you take things forward. But just, yeah, thank you, and very emotional. Thank you.
Heather, thank you. Pippa.
Yeah, thanks very much. I mean, just feel so conflicted in so many ways, to be honest. You know, it's the biggest worry I think I feel is that the direction moving forward, learning from what's happened and making a difference moving forward. I'm very concerned that the structures that are operational are not able or not going to be able to accommodate that the way they are. And I think I think it's a bit much of us to hope that Lynn's going to be able to solve that because it's massive, and it just makes me very sad, because there are so many good frontline people trying their hardest to do the right thing, and they're working in systems that don't make sense, and they don't have ownership or control over those systems. And I think that is terrifying, and I think that is the best thing about the hospice work that we did. I often felt that people we were working with in those research studies felt a sense of ownership, that they could make a difference if they wanted to. And I just wonder how we can spin that feeling out more generally. And I'm quite frightened, is how I feel, Stuart. I think I'm a little bit, because it's wrong that people feel that people who are doing their best are feeling under any duress or pressure, and in fact are even probably themselves short with others because they feel so hopeless and they can't solve things. So that's on a positive thing, because I'm a solutions person, so I always like the ways forward. I have to be honest, the bronze, silver, gold command, approach that Mandy, that you talked about, which I'm pretty sure was operational across the city during, because I think we had one of our professors was very much involved in that, and she used to talk about it. I don't think that should just be there for times of crisis. I think that should be there full stop, and we should actually have that as the way of enabling actions.
Yeah.
So that's
yeah.
So there you go, Lynn. That's something else for you to do in your spare time. But thank you very much.
Thanks, Pippa. I'm going to leave the last word to Lynn. I just want to quickly say thank you to all of you, and thank you in this little kind of bit of feedback here at the end for all bringing your hearts to that and talking about your feelings and about what the emotion is for you that this has surfaced. I'd seen the film before, and for me the film, the first time I watched it, really brought me to the reality of what we'd been through. And it's kind of human nature, isn't it, to kind of push things back, want to forget the awful, horrible, unpleasant things in life and move forward. But it was really important to see this film to remind me, and I think, Lynn, your work's really powerful in this respect, that there are things that need doing, there are things that need sorting out, and we need to not forget. We need to be drawn back to the uncomfortable experiences and the difficult and horrible things that people have very kindly shared today to work forward. Then I want you to have the last word, and then we'll let you go and do what you need to do with the media today.
I think that they've gone on to other people. Well, firstly, I just want to say a massive thank you to all of you who've put it together today. So thank you. I really am grateful. Thank you to everybody who came. The thing is, I'm pushing against an open door with all you good people. And what worries me, that report was 30 voices. It represents 230,000 families. But the people who need to listen aren't listening. And that is government, because we're now being pushed out of the inquiry with the listening exercises, being sidelined to market research companies who worked for Hands, Face and Space and everything. So that's the political, we should never apologize for bringing politics into this. So that's a big problem. And then I'm heartbroken at the turnout, because I want, again, I need those voices to be heard, and they're not being heard. And I just think that is, you know, all this time on now. And you see, we get told we've got to move on, but for those people, they can't move on. They're like stuck in limbo, you know. So yeah, but I'm grateful for the opportunity, you know. I'm grateful to all of you for turning up. Thank you.
Thank you.
Thanks, Lynn. Just a couple of practical things then. Those that turned up, and we had a really rich and valuable conversation. But I hear your point, Lynn, about the numbers being low today, and I'm sorry about that. There's two things that Kate's put in the chat. One's around the support connections that you can access if you feel that today has put you somewhere where you feel you need to just get somewhere to talk or somebody to get some support from. So that's a link there if you wanted to make use of that. And then the other one, Kate's going to be doing some evaluation around this. So if you can please take a couple of minutes just to share your responses through the questionnaire that's there. Will we be sending that link out as well in an email, Joe? Yeah, thank you. Okay. Okay, have I covered everything? Yeah. Good. Okay, I'm getting nods. All right. Thank you again for your time today. I really appreciate it.
Thank you.
Thank you.
Bye.
Bye.
Thanks very much. Bye.